Hello, this is Dr. Lewerenz at Longevity Health Institute and my Madison Heights office, the former Lewerenz Medical Center. And going over some cases, and I just kind of reflected back on one of my morning cases and thought I would share it with you because it's really interesting and educational, and something that's super common that we see. So we had a patient here today, actually I've seen since 2012. He's 52 years old. Even back in his mid 40s, he had very low testosterone, and he had hypertension, and we had him on hormone replacement, a balanced approach hormone replacement wise, and he did very well. His main symptoms back even in 2012 here were fatigue, muscle weakness, fat gain, low libido, anxiety, and high cholesterol. Long story short, back in 2012, his testosterone total was 212 with a free of 3.2. Essentially a very low, suboptimal, as if he was 80 years old and he was in his mid 40s, low testosterone. So long story short, back in 2012 and up to 2017, we treated him very effectively. Did some cardiovascular stress tests, treated his blood pressure, kept his testosterone and estrogen in balance. He lost weight. Actually, his weight in 2012 was 197, and the last few times I'd seen him, he was 186, and time after that was 188, but that was back in 2017. So he went missing in action for almost 2 years. Saw him here today and said, "Hey, how you doing? What's going on?" He's actually currently 52 years old, and he goes, I'm cheating, by the way, looking at my chart, but he was 52 years old, and he said, "What's going on? How you been, etc." And he's like, "Well, you know, my other doctor, my primary care doctor that I still see also and kind of bounce things off, and this gentleman comes from Brighton, and he took me off my testosterone, said it was dangerous and ineffective and caused cardiovascular risk." Now, mind you, years ago, stress tested him, cholesterol tested him, kept him hormonally balanced, he lost fat, felt great, energy was good, better quality of life, and much healthier. So he gets scared, goes off testosterone, does his own research, looks at testosterone and says, well, maybe this is a inappropriate, scary cardiovascular risk therapy and I should not do. So in the next year and a half, he proceeds to gain back all his weight plus some. Now he's 199 today when he came back. He stopped his blood pressure medicine because he felt like he didn't need it anymore, and his brachial arm standard blood pressure was 128 over 90, obviously too high. He said that he was told he had high cholesterol, didn't really do anything about that, and he's back with erectile dysfunction, low libido, tired, fat gain, and basically depressed because he's just sitting around late on the couch and not working out or anything. What happened? Well, basically he was scared, tactics. And here's the thing is this, I'm not even disagreeing with his primary care internist, family doctor, what have you, because if you don't have the knowledge or the education and you don't look at the research and the studies, some of the hormonal studies that come out about testosterone replacement can be scary because it's not done in a personalized way. It's not done in a bioidentical way, and it's not done in the appropriate way, and then also retested and reproduced. So for instance, a VA study that he brought up to me that he had read actually showed near a 30% increase in cardiovascular events in men over 70 that were given testosterone. Well, let's look at this. This study actually was years ago, but it actually was a ridiculous type of study because it had no controls. They didn't give you the amount of testosterone that was injected into these men over 70. You didn't know if they had previous cardiovascular disease or diabetes, etc. Okay, and all they looked at is outcome, and the outcome did look bad. Heart events, vascular events. Okay, I would agree with that. Why would any good healthcare medicine give men over 70 with who knows what dosing injectable testosterone, every 2 weeks, essentially getting a peak supraphysiologic testosterone dose, a conversion to estrogen, and then a trough of drop of testosterone. What we would call very supraphysiologic and inappropriate dosing. Very common, kind of an old school standard, possibly done now still, who knows, at the VA and at hospitals occasionally. That is not a good quality personalized approach to replacing hormone. Actually, any hormone, whether it's thyroid, testosterone, estrogen in a woman, DHEA, what have you, okay? So my point being is this. Of course you're going to see cardiovascular events and risks. Why? They get thrombotic, they get hypervascular because of coagulopathies that can develop. They get thickened blood called polycythemia with too high of dosing. So yeah, you give somebody a 200 milligram injection of testosterone and bad things are going to happen. Obviously, Longevity Health Institute, myself, my practitioners, we do nothing of the sort. We do it bioidentically. We do small doses, very, very, very intricate micro dosing, a little bit more frequently. We use transdermal creams or testosterone pellets in very low appropriate doses to get wellness, prevention, and resolution of symptoms, okay? So, again, this gentleman was scared. Obviously, we haven't treated him yet. We got some labs back. I'm sure they're not going to be any better than roughly 7 years ago. I put him on our central blood pressure cuff monitor because I wanted to really quantify what his blood pressure was and show him. And we did a reading where, if you can see that, but it actually looks at values where you're getting waves of velocity of cardiovascular vascular elasticity or endothelial stretching of the vessel and the reflux wave of that. So it's not just your arm pressure, we call it a central blood pressure, aortic pressure. And in that he actually, so it rules out any stress effect where somebody comes in, oh doc, I had coffee, I'm scared of being at the doctor's office, you're intimidating, I hate going to the doctor, stuff like that. And so you do get a spike of their systolic and even diastolic blood pressure. So we rule that out by getting a central blood pressure cuff meter. And we have that here. It's very advanced, done in a lot of research, used in universities around the country. And then you can say, well, where is your pressure? Well, actually, his central pressure, his diastolic, was no different than his brachial, which is not good. So we treated him. We put him on a low-dose diuretic. Potentially even we'll use something that is a vasodilator down the road, but we're going to bring him back to check his pressure. I ordered actually a calcium score on his heart to just alleviate any concern or symptom to any cardiac event because he is now in his 50s. He had passed stress tests before, but I believe in thorough cardiovascular screening so you know your risks and you know where you're headed. And even if he has a zero calcium score, we'll still watch his lipids and his blood pressure. But let's say he has a little bit of a plaque in his coronary arteries. We'll assess that and see if he needs a cardiology referral or if he needs some simple remediation and with supplementation or things that we know that can pull plaque, pull calcium out of arteries, like garlic, like something called Natobac-TX, like potentially chelation, like Tri-K, vitamin K, MK7, anyway, on and on. But these are things that we know that have natural benefits to alleviate plaque in arteries. My point being is this. Knowledge gives you hope, gives you wellness, gives you prevention, gives you better quality of life. We will, like we did before, resolve this gentleman's erectile issues, his libido issues, his energy, get him off the couch. Probably even if I asked his wife, create a lot more happiness at home and harmony. He's a great guy. He understands it now. I kind of clarified things with him, and he'll be an easy case. But I wanted to share that with you so that you understand that a doctor, and there's many doctors like myself out there, but you have to take a personalized approach. You have to look at the values, the treatment in a personalized way. You have to use appropriate physiologic dosing. You have to look at the outcome of what happens, and you have to look at everybody individually. For instance, this person actually is very compliant, and we got a lot of risk assessment on him, and he's thrilled. So Anyway, know who you're getting your information from. Actually, with my patients, I joke, I say, be careful with Google MD. And also question your doctor and question me and question the studies and the literature, because sometimes even the literature and the studies aren't good or skewed, okay? Go with your heart, go with your instinct, okay? But make sure that you have the knowledge, okay, and it makes common and physiologic sense, especially in hormone replacement, okay? No different than thyroid replacement, no different than estrogen and hormone replacement in women, no different than insulin and diabetic, etc. Okay, so hopefully this enlightens you, gives you some knowledge to share with others. Of course, we're experts in hormone replacement in women and men. We always try physiologic dosing and to alleviate symptoms and your goals, but our goals are always to create wellness and prevention in you, help you thrive, not survive, right? So this is Dr. Lewerenz, Be Well, Longevity Health Institute. Share this with others, like us, follow us on Instagram, and hope to see and help you, or at least this draws you somewhere to get the help you need. Be well.